Hello everyone. Welcome to the Chronic Pain After Surgery Predictive Factors and Prevention Strategies webinar. I'm glad you're here with us today. My name is Tanya Hyde and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability, and this webinar is made possible through the support of the Community Gaming Grant Program through the BC government, as well as through donations and memberships to our organization. And as I mentioned, my name is Tanya, and I'll be moderating the webinar and Q&A session today. And our presenter today is Dr. Stefan Schug. I've just practiced that too, Stefan Schug. And he is a professor and chair of anesthesiology in the Department of Pharmacology, Pharmacy, and Anesthesiology at the University of Western Australia in Perth. He's also the Director of Pain Medicine at Royal Perth Hospital in Australia. He studied medicine at the University of Cologne in Germany, where he also obtained his MD in clinical pharmacology and subsequently specialized in anesthesia and pain medicine. His principal research interests include the management of acute and chronic pain, cancer pain, regional anesthesia, the pharmacology of local anesthetics and analgesics, and quality improvement in healthcare. Thank you very much for being with here, Stefan. I will hand it over to you.
Yeah, good morning, ladies and gentlemen from Australia, or good evening to those of you who are in other areas of this world. It's an absolute pleasure to run you through this webinar, which I think is interesting and important. I will actually start with, but it might slide.
Oh yes, actually if you just click into the middle of the PowerPoint.
Okay.
And then now you should be able to move it again.
All right. I wasn't instructed about that. So the reason why I think we are having this very appropriately at the moment is that the International Association for the Study of Pain has made 2017 the global year against pain after surgery, and you see the logo of this activity there. And as already expressed in the title, this is not only dealing with acute pain after surgery, but with pain in general after surgery, and thereby includes chronic pain too. Now, looking back, it is possibly now nearly 20 years that in a publication in Pain, British pain specialists noticed that of the 5,000 chronic pain patients they surveyed in 10 pain clinics in the UK, over 20% mentioned surgery as a starting point of their pain, and another nearly 20% trauma as a starting point of their pain. And this was the first time that there was a realization that possibly there is a progression from acute and chronic pain to chronic pain, and patients who are experiencing chronic pain might actually have started with this by experiencing acute pain. Now, in this context, I will refer very often in the coming lecture to a document which myself and a number of colleagues have prepared in its 4th edition now. It is the document Acute Pain Management Scientific Evidence. You see here, it was finished around a year ago. If you want to read it, the college is making that available through the website of the Faculty of Pain Medicine of ANZCA, the Australian New Zealand College of Anaesthetics, and I show you the website here where you can download the PDF for free. It is more or less a summary of the complete literature on chronic pain, on acute pain management, and is extremely useful, we think, for you to understand the scientific background, and includes a lot of the topics I present here, but also I will summarize parts of my lectures by referring to the key messages in this document. So let's start. This is from the document. how common is persistent post-surgical pain? This is a summary statistics from a number of publications over the last 10 years, and you can see here on the left side the overall incidence of chronic pain after various operations, but more importantly, I think on the right side highlighted the estimated incidence of chronic severe pain rated as more than 5 out of 10. And you see here that for some operations up to 10 or even 15% of patients can have chronic severe pain 6 to 12 months after surgery. And that clearly is an area which we have possibly not appreciated sufficiently in the past, and this is really the topic of our lecture. Now, I've encountered many people, in particular surgeons, who have told me, oh, this can't be true. And I want therefore to offer you some supportive statistics. This is a statement by a surgeon in the British Medical Journal, which says chronic pain is the most common and serious long-term problem after repair of an inguinal hernia. So there is clearly appreciation that even with a rather minor surgery, chronic pain afterwards can be a serious problem, and you have possibly, if you run a chronic pain clinic, encountered patients, lots of patients, who had a hernia repair and are now presenting to you with neuropathic pain. There's also another attempt to quantify the problem, and this is done by Audun Stubhaug and his group in Norway, who looked at the population of Tromsø, a town in Norway, and when they actually asked patients who had had surgery in the last 3 years, 18% of all respondents described moderate or severe pain. When they excluded all those who had pain which was similar before the operation, they were still left with 10%. And if they said, do you have pain now but never had pain before the surgery, the number ended with 6%. So I think in both directions, looking at a population and looking at outcomes of surgery, we end with a number between 5 and 10% for this problem. And I think this means that there are significant implications for the individual patient, but also for the population as a whole. Now, in a very clever article in Anesthesia Intensive Care, Ted Shipton, the previous dean of the Faculty of Pain Medicine down under here, wrote, all chronic pain was once acute, and I think this is clearly a valid statement if you think about it. Now, let's look at that in more detail. Then we know that many patients experience chronic pain as a result of transition from acute pain. And this chronic pain is, interestingly enough, most often neuropathic, and the statistics vary for different operations. There is clearly also an inflammatory component to some of that pain, but neuropathy is an important component. And the basis we assume is a neuroplasticity with sensitization, which can be peripheral sensitization, but most likely more important central sensitization. So it is interesting in this context to see that this concept is not new, because a medical professional by the name of Kreil published in Lancet in 1913 that pain can cause scars in the central nervous system if the noxious stimuli of surgery have unsuppressed access to the system. And I think this is a rather clever description, in particular bearing in mind that this is more than 100 years ago when we didn't know so much about neurophysiology, and I think pain-causing scars in the central nervous system is possibly a very good description of the process of central sensitization as we understand it now. So all chronic pain was once acute, but luckily not all acute pain becomes chronic. So there must be factors which determine why some patients are developing chronic pain after surgery or trauma, while the majority, 90–95%, are actually healing, and as to be expected, the acute pain disappears with the healing. Now, what are predictive factors? Predictive factors for chronic post-surgical pain are listed here. Again, this is from the scientific evidence document, and we have compiled this from multiple sources throughout the world literature. And if we go through it, there are preoperative factors. So you can be predisposed to have chronic pain after surgery by preoperative factors. The first preoperative factor is female gender. We know that all chronic pain occurs more commonly in females, and that has possibly something to do with estrogen as far as we understand that now, but in this regard females are clearly disadvantaged. Genetic predisposition, I will briefly touch on that, but we are starting to understand that this is a possibility. Inefficient diffuse noxious inhibitory control as a measure of poor endogenous pain control. I will show you some data on that. Then very relevant, if you are already entering an operation with chronic pain, in particular if this is lasting more than 1 month, your likelihood to develop chronic pain after surgery is increased. And finally, and this is possibly underestimated, there are psychosocial factors which predetermine patients for development of chronic pain after surgery, and these include in particular anxiety and psychological vulnerability, and one of the key words here seems to be the term catastrophising, which describes a certain personality trait which is more prone to develop this issue. In the intraoperative situation, there is clear data to show that the more risk of nerve damage an operation carries, the bigger the risk of chronic pain. That explains why amputations, for example, have such a high risk, why thoracotomies have such a high risk, but also if you look at hernia repair with the ilioinguinal and genitofemoral nerve very close to the area of operation, why even a simple small hernia repair can be of problem. And if we look at post-operative factors, then you see many words appearing here again, but possibly the most relevant post-operative factor is the severity of acute post-operative pain in the first 72 hours after surgery. And I will come back to this with regard to more explanations. Now, let's look very briefly at genetics. I don't want to go into the details, but possibly some of you are familiar with the gene catechol-O-methyltransferase, which is quite important for the metabolism of catecholamines, including noradrenaline. And we know that noradrenaline plays an important role in pain control and in endogenous pain control. You see here that there is a phenotype of COMT, or a genotype of COMT leading to a phenotype with an increased sensitivity to acute pain stimuli. This is highlighted in pink here on the left side. So for a given pain stimulus, people who have this genotype will have a much higher pain sensitivity than patients who have this genotype. When people with this genotype are followed up in the postoperative period, and in this case they looked for chronic temporomandibular joint disorder at a later point of time, you see there is a 2.3 times higher risk that people with this genotype will develop chronic pain than with this. And there is therefore an increasing interest in looking at genetic predisposition and genotyping patients entering such studies to identify that in more detail. Now, I mentioned already briefly psychosocial factors, and this is possibly the seminal systematic review on this topic from the group around Edmund Neugebauer in Germany, published in the European Journal of Pain. They looked at the complete literature and came to the conclusion that depression, psychological vulnerability, and stress show a likely correlation with chronic post-surgical pain, in line with many, many other publications in this area. Now, one of the most interesting but also most challenging issues is the question of, does pain predict pain? We have already mentioned briefly that preoperative pain predicts acute postoperative pain and chronic postoperative pain. But what is more interesting and more challenging intellectually is that the severity of acute postoperative pain is the best predictor of chronic postoperative pain, with a hazard ratio of factor 8 or something like this. Now, this opens a field for a number of questions, because this can mean that if we would treat acute pain better, we could prevent chronic pain, and that is possibly partially true, and I will show you some data with regard to that. But it could also mean that possibly something happened in the operation, for example a nerve injury, which meant that this patient has now severe acute postoperative pain, which is already a manifestation of the neuropathic pain they will have in the future as chronic pain. Which in this case it would mean that whatever we do, if you don't address neuropathic pain, would not be as helpful. And then there's clearly the possibility that there are people, for example, with impaired endogenous pain control who have severe chronic preoperative pain. And because they have severe chronic preoperative pain and their endogenous pain control is poor, they will also develop severe acute postoperative pain, and this will then lead in the same patient to chronic postoperative pain. You see, this is actually an interesting area, and I guess possibly a mixture of all three answers is the right one, but we don't know that at the moment from the data we can access. So what that would mean is that it would clearly be interesting to have predictive factors and look at these and thereby establish the risk of an individual patient and possibly implement protective treatments for those who are at increased risk. Now, with regard to psychosocial factors, you can do a catastrophizing scale and identify people who are high catastrophizers. And psychologists from California at the moment are actually working on a little program, a web-based program, to reduce catastrophizing in high catastrophizers in the preoperative period, and that would be an interesting area to go. With regard to prediction of patients by neurophysiological measures, one of the data which appear again and again in the literature is that patients who have chronic postoperative pain have impaired diffuse noxious inhibitory control, or DNIC, which is now in humans more commonly called conditioned pain modulation, or CPM. I will just illustrate to you briefly what you do. You take a volunteer, for example, or a patient, and expose them here to a temperature, in this case contact heat, and measure the intensity of the pain the volunteer describes as this contact heat. You are then, with some time interval, exposing the volunteer at another limb, for example the other arm, with a painful stimulus, which is the conditioning stimulus. You get a pain rating, but if you now initiate the same test stimulus you did before, the volunteer will rate the severity of pain less than before, and the difference between the two is the DNIC. Now, what does that illustrate? It illustrates that if you expose somebody to one pain, this patient will activate the descending pathways of pain control, and therefore the previous pain will be reduced in intensity. You can imagine that the larger DNIC, the more potent the endogenous pain system of this patient is. So patients with good DNIC have a very low pain here, and we know, for example, that patients who have poor DNIC are patients with fibromyalgia and irritable bowel syndrome and a number of other chronic pain conditions. When you apply this to preoperative patients, then you see here DNIC in increasing intensity, and you see here the likelihood of development of chronic pain, and you see the weaker your DNIC is, the more likely you will develop chronic pain after surgery. This was shown in particular by the group around Janitsky in Israel, and if you see here the overall prospective predictor, DNIC was one of the highest together with intensity of acute pain in the early post-operative period, and you can well imagine that these are in some way linked, because if you have poor endogenous pain control, you will have more severe acute pain. So this is an interesting one, and there is another attempt in this excellent publication around by the group around Eske Aswang and Henrik Kelet. They looked at a large number of hernia repair patients who had a herniotomy and looked for predictive factors for persistent post-herniotomy pain. And the first group was the AAS, the Activity Assessment Scale. So this was describing how much the pain from the hernia preoperatively was impairing these patients, and you see the more there was impairment, the higher the odds ratio that these patients would have chronic pain afterwards. But you see here also another interesting measurement, which is a little bit a simplified DNIC, you could argue. They exposed these patients in the preoperative period to 47 degrees temperature probes, and the higher the patient rated the severity of this 47 degree temperature, the more likely this patient would develop chronic pain after the hernia repair. If you modeled together the chronic preoperative pain and the sensitivity to a 47 degree pain stimulus, then you see here in the right lower quadrant the group of patients who had the highest preoperative severe pain-related impairment. And if you were a patient with this severe pain-related impairment being high, then if you would rate a 47 degree stimulus as 10 out of 10 pain, you would have a 60% chance of more or less developing chronic pain. So the estimated risk is extremely high. So you see here that predictive factor chronic pain plus increased pain sensitivity becomes a very sensitive tool for the prediction of chronic pain after surgery. Now, if one tries to go through the whole story of what happens, then one of the best papers in this regard, although now over 10 years old, is from Henrik Kelet and his group in Lancet, and you see the quotation here. They looked at the whole process and highlighted in particular, again, the genetic predisposition of the individual. Then in the periphery, the risk of neuroma formation, which we know, for example, in stump pain after amputation plays an important role. The risk of increased dorsal horn excitability and reduced inhibition, as alluded to before. The risk of the reduced brainstem modulation of pain, and then clearly cortical contributions. And we know now, for example, for phantom limb pain, that cortical reorganization is another important factor in the maintenance of this chronic pain state. One can make it even more complicated. This is a very clever design by the group around Joel Katz from Canada, where they looked at the preoperative risk factors, and you see here the psychosocial highlighted, including catastrophizing we talked about, the biological such as female, the chronic pain before. Then in the intraoperative one, the nerve damage and open approach, possibly linked to nerve damage, the severity of inflammation, the duration of surgery and repeat surgery is another factor. What we as anesthetists can do, multimodal preventive analgesia, and we will talk about it to interrupt this, and finally the development of the complex chronic pain state. And what is really important, we need to see that as a continuum from acute pain to chronic pain. So if I summarize this, I will use the key messages in the college document. Chronic post-surgical pain is common and may lead to significant disability. And I showed you the data to support this. Chronic post-surgical pain often has a neuropathic component. There is significant association with psychosocial factors, in particular anxiety, pain, catastrophizing, depression, psychological vulnerability and stress, and finally the severity of pre-surgical chronic pain, post-surgical acute pain, and the linkage to intraoperative nerve injury. I think this is an appropriate summary of the first part of my lecture, and after we have now set the ground, I want to look a little bit about what we know about prevention. And the problem here is that regrettably the data are not very good, are relatively inconsistent, and we need to do a lot of more work in this area. So first and foremost, I guess you are all aware of that, but I want to highlight this editorial in anesthesiology that we had in the past the classic definition of preemptive analgesia, patients receiving the same treatment before or after, and the only difference is the timing. And all the data in humans do not show sensational benefits from before versus after treatment, and we understand now that this is possibly the case because even if we treat before, but even more so if we treat before, there will be a period post-operatively where there is again full nociceptive input to the neuropathic system with the consequences of pain. Therefore, the thinking has changed to the concept of preventive analgesia, and that is attenuating the impact of the peripheral nociceptive barrage with noxious preoperative, intraoperative, and or postoperative stimuli. And that means we need to extend our treatment by far further, and there's at the moment an attempt to define preventive analgesia as you give an analgesic and the effects exceed the clinical duration of the effect of the drug used, and that usually requires longer than 5.5 half-lives of the drug. And we know, for example, that pregabalin has such an effect. We know that systemic lignocaine has such an effect. So there are data which are coming out which are showing some preventive effect of ketamine would be another one, but could mention here. So can surgeons do something about preventing chronic post-surgical pain? The data are rather contradictory and not overwhelmingly positive in one direction here. There are some data to suggest that less invasive techniques may prevent chronic post-surgical pain, and the best data here are coming from laparoscopic versus open hernia repair, and I will show you these. And finally, it looks like if you are damaging a nerve intraoperatively, for example, the ilioinguinal nerve with a hernia repair, it may be better to cut the nerve completely than to leave it in a partial nerve injury, and the group around Kelet has again done a meta-analysis there which hints in this direction. I mentioned before less invasive is better, and this is again from the publication from Eska Aswang in anesthesiology I referred to before, but now if you look at laparoscopic versus open hernia repair, there is a reduction. The odds ratio is significantly smaller than one if you go for a laparoscopic versus an open approach. This is one of the few large data sets which confirm that surgeons can help prevent chronic post-surgical pain by less invasive and possibly less nerve-destructive procedures. Can we do something as anesthetists? You see here one of the first papers with regard to this from Patricia Labantom, who is still working in this area. You see here, these were patients for major abdominal surgery who had either an opioid-based systemic analgesia here or 3 groups of different mixtures of epidural analgesia. And what they measured first was the post-operative area of hyperalgesia around the wound. If you have ever looked at that, every human being after an injury will develop, due to central sensitization, an area of increased sensitivity around the wound. And you see here with systemic analgesia, this is unsuppressed and rather large, while epidural analgesia at 72 hours post-op is suppressing the development of such an hyperalgesic zone. They then followed up these patients 6 months later, and the black bars here are no post-operative pain at that point of time. And then you see all the epidural analgesia groups have nearly no pain, with 10% here having residual pain, while in the group of opioids there was residual pain, and 30% of patients had residual pain which required treatment. This hinted for the first time in the direction that aggressive regional anesthesia might suppress central sensitization, therefore less hyperalgesia in the acute phase, which might lead to increased or decreased risk of chronic post-surgical pain. This is a German meta-analysis on epidural analgesia for phantom limb pain. And you see here they showed that an NNT of 5.8 is reducing, epidural analgesia is reducing the risk of severe phantom limb pain. We looked at our own patients in an audit here at Royal Perth Hospital, and you see here we followed patients up 6 to 12 months after amputation, and if you had a GA, you had severe phantom pain in around 55%. If you had a spinal for your amputation, it was 31%, but if you had an epidural analgesia for 72 hours, you only had 12% severe phantom limb pain. That spinal anesthesia is superior to general anesthesia has been shown in 2 large case series after C-section and hysterectomy, both from Scandinavia. You see a large cohort of patients who had a C-section under general versus spinal, and pain 10 months after C-section, and around a halving by the application of spinal anesthesia, and similar here for hysterectomy, around a halving at 12 months after hysterectomy. So again, a hint that blocking input into the central nervous system by regional anesthesia, be it spinal or epidural, might be beneficial, and that can even be by peripheral block. This is a Finnish study where they looked at paravertebral blocks with catheters in breast surgery, and then they were either infusing local anesthetic, here the circles, or saline placebo, here the squares, through the paravertebral catheter, and you see, not surprisingly, there is more pain in the initial days after surgery if you use placebo, but very interestingly, 1, 6, and 12 months, the placebo group had much higher incidence of pain larger than 3 out of 10 than the group of patients who had a paravertebral block. So it seems that it can also be regional analgesia, and there is now a meta-analysis from the Cochrane group, and it looks at local anesthetics and regional anesthesia for preventing chronic pain after surgery, and specifically highlights epidural anesthesia after thoracotomy, and paravertebral block after breast cancer surgery, in line with the study I showed you before. So there is really level 1 evidence here for the effect of regional anesthesia on prevention of chronic post-surgical pain. But interestingly, it might not be the regional anesthesia, it might be the local anesthetic, because this meta-analysis from the group around Gary Strickart's showed actually that there is a strongly positive effect of local anesthetics by either route, regional or systemic, for suppressing post-operative pain scores and reducing analgesic opioid consumption. So a significant anti-hyperalgesic effect occurs when the local anesthetic is present during the acute post-operative period, and that is irrespective of it being given as a regional technique or by systemic infusion. This is in line with the two meta-analyses you are possibly familiar, which show a significant benefit for patients after abdominal surgery with perioperative infusion of local anesthetic. There is another interesting data set from the Cochrane collaboration again. This is a meta-analysis of the effect of ketamine on incidence of any pain 6 months after surgery. And you see here these are the various types of surgery, but the overall effect highlighted here shows you a 37% significant reduction of chronic post-surgical pain. Now this has to be seen with some caution, because if you look at the size of the trials, you see that there were overall something like 500 patients randomized in trials which usually were in the size in a size of something like 50 patients or something, and you know that small studies can have a significant bias. But the data are promising, and actually a group of Australians, including myself, has just been successful in getting NHMRC funding for the ROCKET trial. We're actually very proud. It was the largest funding of any clinical project for 2017, 4.9 million Australian dollars. And what we want to do, we want to randomize around 5,000 patients, double-blind, between 72 hours of perioperative ketamine and 72 hours of perioperative placebo, and then assess the risk of development of chronic post-surgical pain at 6 and 12 months, and hope that this will actually give then the definitive answer in this area where ketamine looks as if it could be beneficial. Now, we can go further and look at other drugs, and here the confusion is even more obvious than with ketamine. You see here a very famous trial published in Anesthesia Analgesia by Azokumar Bhuvanendran. They gave patients with total knee arthroplasty 1 dose of pregabalin preoperatively and then a fortnight of pregabalin in a reduced dose postoperatively, and followed these patients up at 3 months, at 6 months. And they looked in this study explicitly for neuropathic pain under the assumption that pregabalin would reduce it. And you see there was a dramatic effect with a reduction more or less to an incidence of 0, accompanied by reduced areas of hyperalgesia and allodynia in those patients who were receiving pregabalin. There is another very interesting study, again in a potentially ideal indication, lumbar discectomy. As you know, these are patients who are coming anyway for the treatment of neuropathic pain radiculopathy. Again, pregabalin was given pre and post-operatively, and without going into detail, more or less for all functional outcomes, including return to work, the pregabalin group was better at 3 months than the placebo group. So 2 interesting results. There was then a meta-analysis by the group around Joel Katz on the prevention of chronic post-surgical pain by gabapentin and pregabalin, which showed an effect of gabapentin and a very significant effect by pregabalin, in particular driven by the Buvanenran study we discussed, and an overall significant beneficial effect. The moment this appeared, there was immediate correspondence to anesthesia, analgesia, with the assumption that there was a significant publication bias because many unpublished studies had not been considered. The subsequent discussion has now possibly been finished by a paper in pain from the French group, who did a meta-analysis which is just at the moment available on the pain website as e-publication prior to paper publication. And if you look at that, then there is an effect of pregabalin, but the effect is non-significant. However, you need to bear in mind that, for example, for the Buvanenran study, they looked not at the published neuropathic pain, but they looked at the overall incidence of chronic pain, and there was a reduction in the study by 36%, which was just not significant, possibly because the study size was too small, but it means that one needs to be really careful to actually generalize these findings, because possibly in certain groups there might be other outcomes. Similarly here, this is a Berg study, and while they focused in their publication on the functional outcome, you see here that for the reduction of chronic pain there was an effect, again not significant, but this was the unpublished outcome of the study. Similarly, there are here unpublished clinical trials where, for example, patients with total knee joint replacement had perfect epidural analgesia, and I think it is not surprising that adding pregabalin here would actually not do a lot of benefit. So I think the jury is still out, but the results are no longer as sensationally promising as they were before. I want to finish with possibly saying it might be enough if we just do good analgesia. This is a very interesting study. They had patients with hip or knee replacement who were then getting standard of care in the post-operative period, or they were giving a routine background analgesia with access to breakthrough medication and preemptive analgesia 1 hour before physiotherapy, and these patients were then followed for 24 weeks. And by just simply improving analgesia in the checkered intervention group in comparison to the control group, you see at 6 down to 24 weeks after discharge, there were by far fewer patients with moderate to severe pain on ambulation in the treatment group than in the control group. So I think this shows quite convincing that we are here in a situation where if we do a little bit better with our acute post-operative pain management, listen to patients' concern, address pain on movement and on physiotherapy, we might actually already gain something for our patients. Again, I want to summarize the preventive data from our college document. As shown to you, perioperative ketamine reduces the incidence of chronic post-surgical pain, level 1 Cochrane evidence. Epidural analgesia after thoracotomy, paravertebral block after breast cancer surgery, again level 1 Cochrane review. Further regional data on many other techniques, and we actually already felt that we need to be cautious, and therefore for pregabalin and gabapentin we wrote considerable uncertainty exists regarding efficacy with contradictory meta-analysis, and this has been even more confirmed, this uncertainty, by the most recent meta-analysis. So watch this space. It will be interesting to see what the final outcome of pregabalin analysis will be. I want to finish off with mentioning very briefly that the World Health Organization has asked the International Association for the Study of Pain to classify chronic pain as a new entity in the International Classification of Diseases, Revision 11 or ICD-11. And I am on a committee for the World Health Organization and the IASP attempting to do that, and I think it is politically very important that we make a chronic pain a diagnosis in ICD-11, and you will be reassured to see that chronic post-surgical and post-traumatic pain, the topic of this webinar, is one of the codings in the future ICD-11, and it is defined as pain that develops after a surgical procedure or a tissue injury and persists at least 3 months after the surgery or tissue trauma. There are more details in this definition here, which will be very close to what hopefully will be finally in the World Health Organization definition in ICD-11. I thank you for your attendance to this webinar. I hope I could touch a few topics which interested you, and I'm looking forward to a discussion and await your questions. Thank you very much for attending.
Wonderful. Thank you, Stefan. I really found that to be a very interesting presentation, and I'm very excited about the work with the World Health Organization. I have made some notes to follow up and do a little more looking into that. I was curious, I want to encourage everyone who's online to go ahead and type in any questions you have into the question box. We don't have any just yet, but I had a question. I was curious, what is the rate of uptake of this research into practice among anesthetists and surgeons?
Very good question. I think the rate is variable, and interestingly and disappointingly, it's dependent on the specialty you work in. From the experience we have, anesthetists are extremely interested in this topic. I have been invited to present a significant number of lectures on this topic all over the world. We are doing that at the various international meetings, and we get always very, very good attendance from anesthetists. I have also been invited by surgical meetings, and one of the most disappointing was a recent one here in Australia, where I was supposed to give a plenary lecture to a conference which could have attracted 1,200 people to this plenary lecture, and we had 16 surgeons in the audience.
That is very unfortunate. All right. Let's see. We still don't have any other questions. I'm trying to think if I had anything else that I was curious about. Oh, wait. There we got one. What is your knowledge of the use of ketamine infusion in the treatment of neuropathic pain?
Right. I mean, ketamine, as many of the listeners will know, was introduced as a general anesthetic. It is a so-called dissociative anesthetic, and in high doses can be extremely helpful if you are in an emergency situation, in a battlefield, in a natural disaster area. And I have used lots of ketamine, for example, when I worked with the United Nations in Afghan refugee camps in the Khyber Pass area, where you have no other technique. Only recently, there was a renaissance of ketamine in very low doses, because it became obvious that its effect as an antagonist on the NMDA receptor, but possibly also some other effects, are actually reducing the effect of central sensitization on the nervous system. And this has opened a pathway for using ketamine as an adjunct to postoperative analgesia, here in particular useful if you have, for example, an opioid-tolerant or opioid-addicted patient where giving large doses of opioids is ineffective, and then you can actually often get very good analgesia from a background infusion of ketamine. And in this context, it has then also become obvious that you can use ketamine as an NMDA receptor antagonist for the treatment of neuropathic pain. There are three treatment avenues currently pursued. The first one is you get a patient with severe acute neuropathic pain into your emergency department, spinal cord injury, brachial plexus injury, and then parenteral ketamine is possibly the most useful emergency treatment of acute neuropathic pain. Secondly, there are pain medicine centers who admit patients for a 1-day or 3-day ketamine infusion to more or less set back the system and reduce central sensitization. And there are first data suggesting that that might be successful, but the problem is clearly you need always a hospital admission, which is difficult to get in these times, and also one has to repeat that again and again. There is a third avenue which we are following at the moment. We are currently developing with a pharmaceutical company after initial trials in our own unit a sublingual wafer for ketamine administration, which patients could take at home to treat neuropathic pain. And we have, for example, in Western Australia now sublingual ketamine as a fourth-line treatment for otherwise intractable neuropathic pain.
All right. Let's see. Somebody else asking or stating that they would be interested in hearing more on why a total nerve injury would be less problematic than a partial nerve injury.
We don't know that. I mean, there are some data to suggest that's also true for spinal cord injury, that, you know, if you have partially damaged nerve fibers, there might be more expression of sodium channels and things like that, which drive peripheral sensitization and increased action potential output from the damaged nerve, but that has never been convincingly shown. The only reason that there is now this hint is that in surgical studies, as I mentioned, including in a meta-analysis of all surgical studies, there was a reduction of chronic post-surgical pain in those patients where a deliberate complete neurectomy was done versus those patients where minor nerve injury was left unattended. I cannot explain it. I'm not even sure that it is really true, but this is as far as we understand the current surgical literature, but we need much more work in this area. What is very clear is that if you cut a nerve while it is blocked, and this has been done in animal experiments, you get much less neuropathic pain behavior in the animal experiments, and therefore local anesthetic is a very successful strategy in any route of administration to reduce chronic post-surgical pain.
Wonderful. Someone asking, and this might be a little too specific, but you can answer at your own discretion. Someone asking, what would you suggest for a person who recently had open heart surgery and has been experiencing increased pain and also some feeling low periods of tearfulness and low mood?
I mean, I think the most important thing in such a situation would be to evaluate the pain and identify if it is neuropathic. We see after heart surgery often either through the sternotomy wound or even worse if it was done through a thoracotomy, increased rates of neuropathic pain in the chest wall. And if one would identify that either by using screening questionnaires or examining the patient, then this would also explain why there might be decreased mood, because clearly neuropathic pain has major effect, much more effect than other chronic pain states, on mood, on sleep, on function. And then it would be most appropriate to treat this condition with first-line treatments of neuropathic pain, such as pregabalin, tricyclic antidepressants, or SNRI antidepressants.
Great. Okay, I think that's all the questions we have, and we're just about close to time anyways. Thank you, Dr. Sugar, for your presentation, for sharing your expertise with us. I really appreciate your time, and also congratulations on getting the funding for your upcoming research. We look forward to those results as well.
Thank you very much, and thank you to all attendees for listening. It was a pleasure to present this webinar.